All right, so it's been quite a bit since we've done one of these. We're trying out a new microphone speaker, so let's see if I come through a bit more clearly now. We have 11 studies to get through. Some are quick, but there's a few where I might need to take my time and kind of rant on a bit. So let's begin. Before I forget, so the current setup where I am just speaking at you without actually showing the study. This seems to be the way that's worked fairly well in recent times past. However, if you actually prefer where I am in the bottom corner of your screen while I am doing these and actually seeing the papers as I read through them, essentially let me know, okay? Without your input, I'm just a guy rambling and popping through on your feeds, okay? First up, effects of spinal manipulation and dry needling on headache and migraine, a systematic review of other randomized controlled trials. Like in times past when we've covered this topic, most of what this comes down to is headache subtype selection classification and figuring out what might potentially be the best treatment for that subclassification of headache. Because, like most other painful conditions, knowing what the person is experiencing from a physiological possibility or plausibility mechanism through their other various disabilities at the time makes rendering treatment potentially much more effective if you have a better chance at selecting ones that have at least reasonable theoretical physiological mechanisms behind why they might help that person. A long-winded way of saying you got to try and match the treatment to the patient in front of you, which is why if you just do a blanket study of does spinal manipulation help with headaches, you'll get a huge variety in answers, where in some participants it was a huge boon. In others, it did jack squat. Same thing with dry needling. And there seems to be, when you go through this study, an overlap where, yeah, dry needling edged out some or different parts of the benefits. So, there's benefits in disability and range of motion, in pain and pain thresholds, etc. And in some categories within an individual headache, each one, dry needling edged out manipulation, manipulation edged out dry needling. There were some headache subclassifications where one had a demonstrable improvement over the other, which means if you're selecting, for let's say cervicogenic headache. So this is one where there seems to be some communication error between the joint complex of the neck and the brain, and that leads to the brain applying a brake pattern like, all right, I don't know what's going on in the neck, something's wonky, so we're going to implement the brake system, which is pain, and that's why somebody has cervicogenic headache pain. Well, adjustments, for lack of a better word, and without me getting into a half-hour ramble of possible reasons on what an adjustment does in this situation, we're just going to say it more or less does the glorified reset button. Like if you have a computer issue, I'm going to turn it on and off again, reset it, and it'll start back up again, which easy way. That's what the adjustment does. So then when that happens, you just get that reset. Patient's headache is like, oh, I don't have to be here anymore because you reset the system. And I'm using air quotes. This could get into a very nuanced conversation, but you reset the system. There's no longer a reason for the brain to go, I need to, establish a headache because there's communication error. Versus others like a tension headache, which can look and smell a lot like a cervicogenic headache, may benefit from adjustments, may not. This is where dry needling may edge it out because some of the mechanisms behind what makes dry needling effective will, in the short term, force a reduction in tension if it's applied correctly. So these modalities can be beautifully effective, whether in isolation if you have the correct headache, or in tandem for a headache that you can't quite, you know, pass the sniff test of, is it exactly cervicogenic? Is it exactly tension? Maybe it's migraine, and the patient is open to trying these treatments towards their migraine in conjunction with other things like nutrition, sleep, and depending on the severity, maybe um, vestibular rehab if there's a vestibular component, and or medication. Like There's one thing that I wanna say when we have discussions on these sorts of reviews, and that's I don't like studies that do a proposed mechanism for a condition with one modality and blanket statements say that that modality is either, the gold standard now or has no value in the patient's care because of how complex the human condition is, as well as the fact that if you just, again, using my example, talk about headaches and adjustments, any individual study could either show it's the best thing on God's green earth or the worst thing, when in reality, hey, did we ask the next level question? All right, so headaches has as a treatment approach. Let's subcategorize them with confirmed, multivariate people saying, yeah, we know it's that type of headache. Include this person in the study. Um, like there's so many things that are still being juggled. There's so many things that aren't being answered or asked as further level questions to refine the research, and people will take a lot of this research as gospel on should you do something or should you not do something, when in reality, it is so much more complicated than that. I actually have an example up here of a conclusion that the researchers reached that is, for lack of a better word, garbage. And I'm going to get into why. So it really behooves everybody to have multiple looks, multiple takes, and multiple viewpoints on research as a whole. And I want you guys getting multiple people in your threads talking about different research articles, different things in the literature, because I'm me, myself, and I only have my own eyes. I do the best that I can, but I make mistakes. I make my own interpretations on what these guys did for the research. And there's potential communication errors from the researchers to clinicians where, all right, so you have research which is being done in sterile environments because you're trying to address and answer a question and figure out if something is worth pursuing either further for more money, time, and effort, or is it clinically relevant that should be then dispersed out into us clinicians? And then us clinicians have to take that and figure out, is what they're saying accurate? Does it make sense for this person, this environment? Was it a well done study? Like there can already be a communication error. Then we have the lay population who have the condition that is relevant towards, you know, what is their viewpoint of what the researcher says? Is it matching what the clinician is telling them? We already have three possibilities for error. And then there's just the lay people in general that may or may not have a reason to look at this research and apply it in a way that may make sense or may not make sense. And it can get very confusing very fast. So, like with anything else, get multiple sources to come up with your own opinion. I appreciate it if you trust me, but just like my pastor says, like everybody else that I highly respect says, you can trust but verify. Okay. That's what we try and do in our daily life. And it's just something I encourage you to do as I talk through the rest of these 10 studies. But that's my little pet peeve on things like this. Um, but yeah, that's what we have to talk about as far as spinal manipulation, dry needling, and headaches for today. I'll move on because apparently I am in a preachy mood. BMI, body mass index, as a risk factor for recurrence and frequency of resurgery after lumbar spine surgery. Um, we've talked about studies like this in the past, and this shows the same thing. I think the last one I talked about was resurgery rates when it came to knee surgeries and knee pain and knee replacements. And this one essentially shows the same thing. I can't remember the rates off the top of my head, if they exactly match, but the direction is the same. So this one had almost 300 patients who underwent single-level lumbar discectomy for degenerative disc disease at a teaching hospital, and then they took a look at who needed um, additional surgery afterward. So recurrence occurred from the 300 adult patients in about 30, so almost a 10% recurrence rate. Patients with recurrence had higher BMI at initial surgery compared with those without a recurrence of the issue that led to the surgery. Overweight and obese patients accounted for 64% of total recurrences. Putting it through a regression model, so doing some math on it, they basically found that for each kilogram increase in BMI, it increased the recurrence odds of that I believe it was the disc issue. Yeah, degenerative spinal disorders, being able to flag it on MRI, increased the odds by about 38%. Bum, 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 bum. Modic changes were the strongest independent risk factor, and their conclusion was elevated BMI is significantly associated with increased recurrence and reoperation after after lumbar discectomy. Suggested intervention includes preoperative BMI optimization to reduce the risk of resurgery and improve postoperative outcomes. Now, I agree with that. And what I want to just take a moment and discuss is, remember, it may not be, even if this is a singular factor, BMI as the thing that we're using as a risk factor analysis, BMI in and of itself has a lot of potential reasons on why it leads to recurrence rates and the need for additional surgery. That isn't just the added tissue weight. Can that be a factor? Oh yes. But it shouldn't be the sole factor. Like, oh, I'm going to reduce my BMI pre-surgery because the additional weight is going to add stress to my back. No, I don't want you thinking that, because that's a false conclusion. You should reduce your BMI because a lot of what leads into having a poor BMI is what actually causes the recurrence rates. And let me explain. Typically, we see associated patterns of those with higher BMI to have reduced desires, habits, etc., of overall movement, reduced efforts, oftentimes put into dietary and nutritional status. Higher BMI also typically occurs with or co-occurs with additional comorbidities, so cholesterol issues, heart and cardiovascular issues. And so what we see is BMI could be viewed as a marker that is associated with additional factors that will have poor outcomes when it comes to something major like surgery. So BMI is like the canary in the coal mine. Hey, patient, your BMI is 35. That's pretty high going into the surgery. We want to reduce it, not just because the reduced weight will mechanistically reduce the strain your back goes through. That's wash that. We want to reduce your BMI because we know that, or it is something that will reliably coincide with you improving your lifestyle, life factors as a whole, which is what will improve your surgery outcomes and your surgery odds. So, hey, you're going to go from a 35 BMI to a 22. That means in order to lose that weight, even with the advent of GLP-1s and all of those things that help with the weight loss side of things, BMI could be just a reduction in weight or an increase in lean mass, muscle tissue, healthy bone. That's another side of the equation we have to consider. So, is somebody just having excessive tissue of non-muscular origin, or are they just lacking the lean tissue going into this? And if you want to improve BMI, you can do both. You can drop the excess weight, which we know is correlated with everything that I already said: metabolic, cardiovascular diseases, comorbidities that impact surgery, lifestyle factors that go into affecting surgery. And then those lifestyle factors also correlate with improving BMI because they're not just taking away the excessive fatty tissue, but you're typically also improving the quality of the quote unquote healthier tissue, the muscle, the bone, etc. So going from a 35 to like a 22 BMI, hey patient, I know in order to improve those numbers, you're likely losing a bunch of weight, which means your lifestyle is improving, and or your healthy tissue is going up, which is making you more robust and capable of handling the surgery, and your body has more ability to adapt to what it's about to go through. So there's a lot to unpack, even with just the whole BMI thing. It's useful because it lets us communicate using one number if a patient has a good risk profile or a poor risk profile going into a surgery. But even that number has a lot of factors going into it that may need addressing one on one with the person in front of me. So let's look at, and I'm going to use layman's terms here, so don't come after me in the comments. Just give me some grace right now. Two patients, both have a BMI of 30. One is excessively overweight with purely non-muscular tissue, fat. The main goal for them is going to be weight reduction, which means we may want to hit the nutritional side of things much, much harder and get them on a general physical plan of just, hey, walk, move, whatever, do that. Another person may not be actually that overweight, but they have atrociously poor lean body mass for their weight, poor muscle, poor bone, which means we need to not, from a nutrition side, reduce their caloric intake. We may need to actually increase it to give them the ability to build muscle, bone, etc. We may need to include other risk analyses like, is it bone that is the issue? Do we need to send them in for like DEXAs and consider nutritional supplements and medications to improve bone mineral density, as well as get him on a more specific strength training profile? BMI is the same, person in front of you is different, approach to get to a healthy BMI going into a surgery, way different. Single number. We both know both of them won't have handled that surgery well, but the reason or what we have to do with them is entirely different. So, just fun little food for thought that I yeah. Well, I want to move on because again, I'm already too long into this and we've got 9 more studies to go. Beverage break. All right. Step down biomechanics in a unilateral, one-sided patellofemoral knee pain. Cross-sectional study in young females. Um, what do I want to say about this one? Let's jump to the conclusion, and I think this will kind of kickstart what I want to say. The conclusion from this study was that young females with one-sided knee pain exhibited compensatory biomechanical alterations in even the unaffected limb. Prolonged overuse without timely intervention may increase joint stress and lead to long-term dysfunction. Early bilateral intervention, such as hip abduction, so swinging your leg to the outside, and external rotation muscle training, is essential to prevent such complications. Yes and no. Um, is it any surprise that if you have a very painful knee, that not only the knee itself is going to be going through a protective pattern, but that very protective pattern in and of itself will lead to the other limb changing what it does, how it does, and why it does it? Oh, yeah, obviously. Early bilateral intervention, such as hip abduction and external rotation muscle training, is essential to prevent such complications. I don't know if it really is, in the sense of what they're talking about. I mean, you don't need to specifically target or do some hyper specific movement to address this risk profile. Honestly, there we could talk about age group, we could talk about a lot of other things as far as the errors of the study go, but I think the biggest one that I'm coming to is just the conclusion, because if you have somebody that just reads that sentence, hip abduction, so training of the hips going to the outside, along with your external rotators, which a lot of them do the same job, you're thinking, oh, I need to really train my glutes. And people may or may not just hop on, you know, various machines like an abduction machine where you sit and you put your knees in it and you're just opening your legs and closing your legs. They they'll go into things like maybe just bilateral glute bridges. So are you training quote unquote the right muscle tissues according to the study? Well, yeah, but there's a lot of problems with that. One is you don't even need to get that specific with it. Two, oftentimes people will look at that and not load it enough anyway. And three, whatever happened to just understanding that a lot of your compound movements will train it anyway? Like, you tell me that a really good squat isn't going to hit most of that from the get go, but I feel it in my quads. Yeah, that's just the one that's working the most at the moment, or that's the one that you're working the most in the moment. You could honestly just take that same movement. Do you do a high bar back squat, low bar? That's gonna shift it more into the hips. You're gonna feel it more in the glutes then. Maybe you do front rack, front loaded. Maybe you change it to just a simple loaded lunge. You don't need to overthink these things. You just need to understand the patient profile in front of you, understand that there's common compensations that happen, which isn't bad, and you just need to put the person on the right path again because the doom and gloom of this is like, oh, prolonged overuse without timely intervention may increase joint stress and lead to long-term dysfunction. You don't really need to try and scare somebody into doing something the way that these people are. You just, hey, you got knee pain? You're probably gonna work around it for a bit. Your whole body's gonna work around it. That's fine. And we just need to find avenues for you to get back into training. And, if there was, you know, any major weak link that we can address, great, we'll do it. But we don't need hyper specific, esoteric, crazy, weird wackadoodle exercises to do so. Um, You just need a comprehensive program. You can focus on compounds, add in a couple of accessory movements, make sure that the person is still getting their cardiovascular fitness in, and address the lifestyle. You're going to handle 95 to 99% of most musculoskeletal injuries in front of you. This game is a game of exceptions, not the rule. The rule is find what you can tolerate, train it, make sure you hit the whole body, and make sure you train hard enough so that you get close to failure in any one of your preferred training methods and styles, and you'll adapt, get stronger, and more resilient as a whole. So, yeah, I mean, small little segue there. Well, I don't want to train super duper heavy with, maximum weights where I can only do 1 or 2 reps, which I love doing that. So I ask you why, but I get it. You just need to make sure that you get close to failure in whatever you're doing. So do you like the higher rep stuff? Great. Just make sure you get close to failure. I would despise doing a 10 by 10. Oh, give me 10 sets of 10 reps. I hate that personally. I don't. But if you do, just make sure that the weight selection gets you close to failure because then you can get stronger. Then you can get more resilient. And again, that's the rule. So with this knee pain, yeah, you're going to compensate a bit. Find a way you can move, train, tolerate these movements to the best of your ability. If you need some help doing so, find a reputable provider. Sure, I'll throw myself into there, such as myself or a lot of the people that I know. So if you're not close near me or et cetera, don't want to work with me, still hit me up. I'll find you the person. Um, and just keep training. Don't worry about, well, okay, I know in this movement my knee dips this way, so I have to think about this and do that and make sure that my knee is just so. And it's just like, did you ever think that you might be overthinking it and you're kind of causing that problem from the get-go when you're rehabbing this thing? Like I've seen that too. Uh, Put another way, it's like, have you ever tried to avoid the pothole and you're focusing so much on the pothole that you just happen to drive over it and hit it? Yeah, you were so focused on addressing the problem, you caused the problem. And I think that's the balance or the fine tuning or what makes honestly what it might be what makes a decent clinician a great clinician isn't the fact that they're going to do anything different with a patient that a decent clinician will do, but they're able to give a person and adapt their approach to match what that person needs in the moment. Put another way, there may be some people that you do want to give a little bit more cueing to because they, at the time, would benefit from it more, whereas others with the same condition, you may want to actually get them out of their own head and essentially coach them down because their focus on optimization and perfect form in the moment may actually be hindering their progress and actually prolonging their rehab. So it's kind of like the tale of the BMI example I gave not too long ago. Same exact BMI, two different approaches. Same exact knee pain, even if they have the same compensatory patterns, even if you can somewhat predict it, which is what this study claims to do, the approach to treatment can quite literally be the exact opposite, even within the same movement. Like, let's just take a unilateral lunge. You may just have somebody that is going through the motion and just smashing their knee into the floor, that back knee into the floor, and just getting through the movement because they just want to get out of it. They want to do the movement. It's like, hey, he told me to do the movement. If I do this, I'm going to get out of pain. I'm just going to smash, 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 smash. In that case, hey, I'm going to force you to slow down. I'm going to cue you more, and I'm going to make you own the movement and the position, etc. So slow it down. Let's focus more on, I don't care, concentric, eccentric, that doesn't matter for the point. I'm going to be more prone to guiding them and cueing the movement itself. Whereas, quite literally, I have a few patients in mind that I've had to do this with, and like I can picture them now. Same person, same movement, the lunge, they go so slow to try and avoid around the actual painful process, whether it's they don't trust me, they don't want to go and feel the pain, etc. I get it. I'm going to do one of two things. Either I'm going to say, fine, let's not rep this out. Let's find that position. And now I'm going to change it to an ISO, an isometric, because of your personality and what you're demonstrating me. So, from a mechanistic perspective, doesn't matter between reps and ISOs, but from your personality, it looks like you're going to handle the ISOs much better. Testing, right? Um, so, yeah, or I might just gamify it, so force them to take their mind out of it and just give them a task. So, hey, you can't think about it. Your only job now is in 4 seconds, you gotta be able to touch that and pop back up. Completely different coaching style, same conditions, same movement, etc. Same compensatory pattern, doesn't matter, okay? Don't think you have to be hyper specific. You just gotta be a good coach. All right. That's 3 studies in, and I think I've been talking for half an hour. Let's speed some things up. The efficacy of kinesiotaping combined with exercise therapy on patients with, oh, look at that, patellofemoral pain syndrome, a systematic review. Look at that. If you're able to exercise it, and some people like the exercise with tape, they seem to do better. Shocker. So kinesiotaping, it can help because the patient has an external stimulant that helps them get through the exercise. Doesn't do anything spectacular beyond that. Now, there are times where I've used dynamic tape, which do I have my bias? Yes. I am very biased towards dynamic tape, but it's for a very good reason because you can actually add springs, add resistance profiles, and aid in a person's actual movement profile. So, just like I said, that whole cueing thing, we can add this to their regimen to improve their ability to go through movements. And by aiding in their ability to go through the movements, you remove barriers and they're going to get better faster. So I love this one. It reinforces what we do and how we do things with, I'm not going to say an inferior tape, but a tape that can only do so much. It's nice to see that we can still get a lot of benefit. So, all right, sweet. That one only took 2 minutes. Let's see. Next up, does the timing of ACL reconstruction affect meniscal tear type? This one kind of said yes, but then in the end, it also doesn't matter. So let me jump down here to the conclusion. Uh, our findings show that the delay of the ACL repair is associated with an increase in medial, so inside, basically toward the groin side, not towards the outside, is associated with an increase in medial meniscal tears and bucket handle tears in particular. However, despite the average surgical delay of 9 months, all meniscal tears were found to be repairable. So even if you develop these tears, have a higher risk of these tears, and have a higher profile of developing these subtypes of tears, they're repairable anyway, which can happen and coincide with you getting the ACL repair anyway. So at the end, okay, yeah, it happens. Yeah, there's a risk, but does it matter? And that's a question to have between the surgeon, yourself, and the person rehabbing you. Because if you're delayed 9 months, you should have been in rehab and some sort of physical therapy a long time ago. This isn't a I'm sitting on my hands for 9 months and going into a surgery. This is a I'm probably going to go into surgery. And how long is it, doc? Is it going to be 2 weeks from now, 3 months from now, 9 months? Doesn't matter that much in general. There's a few instances when timing may be more particular, but for Gen Pop discussions, doesn't seem to be an issue. Um, this study suggests that not only timing, but also tear type, patient expectations, and surgical techniques do affect repair success. The high rate of bucket handle tears in our study may be explained by yada, yada, yada. Can also be explained that these tears cause the actual mechanical symptoms that get patients into an ortho to be referred to for surgery. So what they're saying there is these types of tears may pop up more in the study because these are the ones that are more likely to cause symptoms, which cause patients to go in, which causes them to get caught. So it's not necessarily that they're more often, they're just the ones that patients complain about the most because they feel them more. So they're going to go in, and because they're going to go in, they're going to get caught more. Make sense? Um, in the current literature, there's no clear consensus on the actual optimal timing for surgery to preserve the meniscus. Therefore, various prospective and randomized studies with larger patient groups are needed to address this question. Um, so, yeah, long story short with this one, you have time. Are you at risk of developing any additional disabilities? Not necessarily. Uh, it really seems to be at this stage with the evidence that we have, which again, new evidence means new opinions and new clinical discussions. But at this time, if you are considering a tear, should I get it repaired? You have time. If you're being told you will develop or will likely develop a meniscal tear if you don't get this repaired right away, is that true? Possibly. Again, they say yes, but they have that caveat of maybe it's just because um, the tears that develop after the ACL tear for the meniscus develop symptoms that they'll feel it more. So take your time and address everything in your life of do you need to go through the surgery? That discussion should happen between yourself. I would recommend 2 to 3 surgeons, seriously, as well as 1 to 3 different rehab people that are going to be either rehabbing you prior to the surgery, rehabbing you despite the surgery, etc. You have time for those discussions to figure out what's best for you. I am not really geared one way or the other when it comes to your particular case. I just have like my own personal, opinions and clinical ideas that I will relate to you all through this, to my patients, with frankly an understanding that there's time. So you don't need to rush into anything. And I'll tell patients this all the time. Hey, like a guy comes to mind, like, hey, I just let's see, when did I see him? It was a couple months ago. He recently tore it a week before seeing me, and he already saw an ortho. He saw everything, and he was told surgery this. But then his friends said no, and it was confusing for him. And I literally laid out this case. Hey, you're at a threshold for your age as far as is it beneficial or not, which doesn't play into your favor of just saying yes or no. Um, you need to be able to check a few boxes off for work. So we ask questions like, are you going to back to high level sport? What's your lifestyle like? What are you anticipating doing in the upcoming years? All of these things we were asking him to try and understand what may be the best approach for him going forward. And for him, the linchpin was just knowing that in a few years, he has a higher risk if he doesn't get the surgery of having a feeling of general instability, which is something that he didn't want. So what did he do? He got surgery. And now he's in rehab. That's all there is to it. Other people may be fine with that little bit of feeling of instability because they're not doing anything where it really plays a factor into their life. So they can just rehab the bloody thing and be done with it. But again, these are all discussions with the person at the time, and they have to take in a lot of different factors about what is best for the person in front of you at the time. And what I don't want to have happen, and what I do see the study highlighting, is don't rush into an answer because you think you're on an extremely tight timetable. Like, oh my gosh, this isn't like a life-threatening fracture, life-threatening condition where time is of the essence. I mean, clearly, this study had an average delay of surgery time of 9 months, 3/4 of a year. Well, I can't see a doctor for 3 weeks. So schedule it. Get their opinion. Well, it's going to be 2 weeks after that that I can talk with the other doctor. So schedule it. I mean, you've got the time. Okay. All in all, that's 5 weeks from when you tore the thing. You got 8 more months that was, again, if you're just going by the average, you've got 8 more months before you hit the average before these people had the surgery. Okay? Take your time. Get multiple opinions. Figure out what is the best, legitimately the best for you. Speaking of, this one was kind of fun. So we just talked about his surgery rate for you with ACL tears. This is a uh, what is this one? Is this a cohort, a case study? Cohort study. Okay. So not very high on the evidence, but this is one of those that's starting to do some clinical interventions to ask some questions. So can you spontaneously heal meniscal tears with ACL injuries? So they wanted to quantify the location and morphology, and if you could spontaneously heal a meniscus tear when it came to having an ACL tear. So background info. Acute anterior cruciate ligament, the ACL tears with meniscal injuries elevate post-traumatic osteoarthritis risk, according to other uh, published studies. While early ACL reconstruction does remain the prevalent intervention, emerging evidence suggests that delayed intervention may enhance meniscal preservation. Oh, look, it says a little bit of the opposite of what the previous study did. Amazing how that works and why you need to have, like, we need to go through it because these things will fight. But let's go through what these people found. Methods, not super important. Where's the actual? There's one bit in here though. Bum, 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 bum. So the definition of the healing that they were looking for, that's the important part of the methods. Spontaneous healing of the meniscus was defined as complete fibrous union observed during arthroscopic evaluation. So not just MRI, but they were in there and looking at it. A total of almost 3,000 patients were included. They subclassified which tears had the best spontaneous healing rate, which isn't super important at the time because this is prospective. Like, I'm not going to spend 5 minutes talking about types of tears here. Let's just go to the trend here. The overall trend of the spontaneous healing rate of meniscal injuries in the setting of ACL tears increased over time during the first 8 to 12 weeks after the initial injury. The spontaneous healing rate was highest at 12 weeks and then declined afterward. So this seems to be something where, in the last study, it didn't matter about timing if you're going to consider the surgical route. If you were going to try and guarantee the best possible effect you had of avoiding the surgical route, like, hey, actually, no, that's the wrong way I wanted to phrase it. Hey, I know for sure I don't want the surgery. Then it's like, all right, then we got like this 3 month sweet hot spot here with the 8 to 12 weeks being a pretty big key. Um, Compared with the mean level of early intervention groups, so people having surgery in less than 8 weeks, The 8 to 12 week group, so if you actually gave the knee time to heal, they only had to heal or repair the ACLR. So I guess one thing that I should do is take a step back and let's clarify. So I was saying no surgery, and I meant no surgery in this instance for the actual meniscus side of things. So these people were subclassified into groups as far as when do they get the ACL repaired, um, because they were considering the meniscus injury that we talked about in the previous one as a factor of when and how and why they wanted the surgery. So it appeared that if you wanted to just repair the ACLR, there's about a 3-month spot, a 3-month window where you can, and I believe you keep the knee in slight flexion throughout the full 3 months. The meniscus actually has a great chance of spontaneously healing going into an ACLR repair, which means you can just take out the whole, well, do I get it repaired? Do I not? Oh, I'm gonna get it repaired because I want my meniscus to be preserved. Well, then it's like, okay, then we should probably put you in the ticket of 3 months. And even following my previous example, well, but it's going to take me 6 weeks to get multiple opinions. Yeah, you still have another 6 weeks, and if you have a surgeon that knows something like this, you can get the surgery scheduled within that time frame easy. So I guess one thing that I got to pull back is me saying if you want to rehab it purely conservatively, scrap that. That was my bad, my misrepresentation of what was going on here. Um, so what's really happening is timing of ACL because of meniscus. And if that's a big factor in your reason to get the surgery, then there's going to be a sweet spot to allow it to spontaneously heal where they don't have to go in and repair it anyway. Let me see if there's anything else in the conclusion that I need to talk about. Um, Well, the only thing that they said was you have a 1.5 to 2.5 times greater healing rate in the meniscus if you hit that 8 to 12 week time point versus earlier. So I guess for me, it's just reinforcing don't jump into it within the first 2 to 3 weeks because you happen to have a tear. Still get your time to get multiple opinions. Still take the time to figure out what's best for you overall. And if the meniscus is a factor, you and the 2 to 3 surgeons you talk to have a beautiful window at 8 to 12 weeks to give that meniscus time to heal, um, so that it's not a factor going out of surgery to rehab the rest of that ACL. Hopefully, I didn't make this one too confusing. In summary, what I said about doing purely conservatively, this one found the sweet spot for meniscus considerations because it allowed time to spontaneously heal. But if those are not factors for you or major factors on answering the question of do you do surgery or not, then I guess this study is a moot point. Right. Halfway mark. Whew. Effects of exercise on pain, fatigue, and quality of life in people with fibromyalgia. Like every other systematic review I found, it helps. Exercise helps fibromyalgia. This is one of the few where there are exceptions. So with most people, it's, hit 300 plus metabolic met minutes a week, or just like moderately active movement minutes a week with 2 resistance training days, etc. This one they tried to quantify, is there a different threshold for people that have fibromyalgia, just given the nature of the condition? And they gave a more conservative answer where they basically said, yes, exercise does significantly improve pain, fatigue, and quality of life in the fibromyalgia patients. And it seems that in order to alleviate pain, fibromyalgia patients currently are recommended to engage in aerobic exercise for a minimum of 8 weeks to see benefit. 60 to 90 minutes per session is what was studied, twice weekly. but they found that they didn't want these patients to exceed 180 minutes a week of that aerobic training. Because again, you have some patients that will, I don't want to use the word overtrain because I don't think that's as much a thing as people think of, but what the body does to adapt after exercise combined with what the patient's already going through with fibromyalgia, it is much more difficult to manage and see legitimate benefit of the exercise itself. It's still beneficial. And, if we can, I'm still going to encourage a patient as much as they can to tolerate more than what's recommended here. But there's a reason that they're considering 180 minutes as a threshold because, again, it gets more and more difficult for the body with fibromyalgia to not turn symptomatic after that 180-minute mark, which is not what we want. So this is one of those conditions where it's an exception, and it's one of those, we'll respect it. I'll still toy with trying to get patients more, but I'll respect it. And again, more evidence, always better. Um, yeah, this one's actually straightforward. Sweet. Maybe we can speed things up here. Um, oh, this is the one that I want to at least make sure that I hit my point home. Um, this one actually kind of makes me a bit angry. Biomechanical comparison of two squatting protocols in adolescents and young adults with femoral acetabular impingement syndrome. So there's a couple of things that we're going to have to note about this study. The first one is this is in young people, adolescents and young adults. They have a condition that is typically painful and will lead to a naturally changed pattern anyway, from femoral acetabular impingement, FAI. And in that condition, we have really one of two, and sometimes both, things happening. Either with the femurs, you have the actual ball and socket, kind of like a shoulder, but it's got a better socket. So you have the ball. The ball may be an abnormal shape, causing some sort of a pinch or reason that a person's leg gets painful. So rather than a nice sphere, maybe it's an oval, maybe you get the idea. It's not the shape that's ideal, so it can cause pain. The socket, maybe the socket is way too shallow, which wouldn't be impingement, but there's subtypes. Or maybe you have like these extra bony claws that are kind of coming around the actual ball itself. So rather than, where's my camera there? There it is. So rather than, fitting nice and allowing movement in here, maybe we have additional hooks where it can move certain ways, but if it moves the other, you jam into one of those bony hooks. Well, the tissue isn't going to like that. It's going to lead to pain, which is why you have this femoral acetabular impingement syndrome. It's running out of space faster because of its shape. So we already have a condition that's going to cause some sort of potential compensatory pattern like the patellofemoral pain syndrome, which again, you can work with it. But that's not the reason I'm angry with this study. Um, let's see if you people can catch it in the intro, but you will for sure catch it in the conclusion. And I'll just read this whole thing. Their intro. Squatting is an important activity of daily living which can be particularly useful in the management of FAI. However, double leg squat protocols can vary significantly, potentially impacting biomechanical outcomes. A squat with a hold before the ascent phase represents one variation which increases muscular endurance demands and may elucidate such impacts. The purpose of this study was to identify biomechanical differences between a traditional squat and squat with hold in adolescents and young adults with pre-operative femoral acetabular impingement syndrome. Did you catch it already? I'm going to read the rest of the study, give you some time to think, but let's see if you come to the same conclusion I did. Participants undergoing primary unilateral hip preservation surgery for FAI completed two squat types assessed via 3D motion analysis. So the FAI was already bad enough, or at least something the patient wanted to have addressed because it was impacting their life. So they were going to go into surgery, and they wanted to see what squats were looking like for these patients going into that. The traditional squat was performed with descent immediately followed by ascent. So basically, you sat down, you pop back up, like anybody's seen in a gym for people actually squatting. Boom, 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 boom. There's a there's I mean, there's different phases to it. There's the transition phase, the amortization phase, and there's reasons why people squat that way because you get a little bit of a spring effect, this little pop up from the muscles changing from eccentric to concentric and tendon lengths. Like there's a lot that can go into it on why the traditional squat is the default and why people do it and can squat heavy with it, and why they can't typically squat as heavy with a paused squat, which is essentially what they're describing here. Um, because it's like, additional time under tension with that heavy load. Well, it's like, yeah, that's going to strain the body more, which is what they're thinking. Hey, if we give the squat hold to these patients, that's going to have more endurance demands, which could be very beneficial for the hip. Like, you kind of see what they're doing, but let's see where they go off the rails. Continuing in the methods, the paused squat included a 3-second pause at the participant's lowest comfortable position. Joint range of motion, arms or moments, powers, and squat depth in participants' preoperative limb were compared with each technique. What do you think they found? Like, seriously, what do you think they found? Participants squatted lower in the traditional squat than the paused squat. Maximum hip, knee, and ankle flexion were greater in the traditional squat. Peak sagittal moments and this and that, and peak power generation were also greater in the traditional squat. It's like you didn't need to do a study. You just didn't for that. Like if you're asking, what is the power leakage for a person, or what does the person naturally do? Like, okay, that's a different question. But trying to make the argument that FAI, femoral acetabular impingement, has anything to do with the results of this study in and of itself is, in my mind, ludicrous. Okay, discussion. Participants with FAI squatted to a shallower depth during the pause squat compared to the traditional squat and displayed altered biomechanics accordingly. Given these findings, greater standardization of squatting techniques is warranted as technique variations may affect outcomes, and researchers must consider potential adjustments made by those with FAIs in their natural squat movement. Spare me. Like, how did you go from like how? Okay, anybody who's trained before, let alone anybody who's coached people before, you are not going to naturally squat as deep in a pause squat. Why? Because you know there's a pause. I have done both. I do lots of different types of squats all the time. I can tell you I don't squat as deep with a pause squat. Why? Because I know there's a pause. And if I want to set myself up to get out of the squat where I don't have that additional bounce effect from the transition that a traditional squat has. So that traditional squat, I told you, you get that little bump back up because your body is springing together. You get a little additional kick of force, which lets you do the traditional squat. The pause squat is so effective because it takes it out of it. You are forced to use a lot more concentric power, or it's not power, you're forced to use a lot more concentric muscle to get out of it. So if you have trouble in a traditional squat of ascending, like you're good controlling it down, but you can't pop out of the pocket, you're gonna program pause squats because that's all the bloody thing does. However, if you're training pause squats just to train pause squats, and you tell any layperson, FAI, pardon my language, FAI be damned. They are not going to squat as deep because the concentric demand is going to be so high. They will not want to squat as deep. That has nothing to do with the FAI. at all. That is a biomechanics, almost a 101. Hey, you're going to take out a natural mechanism of the body by forcing a pause. You're going to increase the concentric demand. How is the body going to orient around that anticipated challenge? By not squatting as bloody deep. If I shorten my distance, that I'm going to have to use more muscle, that is a natural strategy anybody who's done pause squats is going to use. So if a traditional squat, I'm going to squat this deep. Oh, yeah, because you're bouncing out of the pocket. So your concentric demand, basically, it's like descend, 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 pop. The amount of pure concentric may wind up being about the same. Worth actual study and debate. That would be worth studying versus, well, people with wrong, 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 wrong population, wrong presumption, wrong everything. You could have done this on anybody. Gen pop. What is the natural compensatory mechanism or action that a person takes when they know they're going to go into a pause squat, and why? What is the natural concentric overload that a person is doing between the two? Like, do you get more pure force, or is the compensatory strategy meaning that you're going to have the same concentric action between the traditional and the pause? Like, there's so many different questions that you could have actually asked between a traditional squat and a pause squat to get relevant information from a Gen Pop standard, and you tried to subcategorize it just with an FAI, which basically wastes all of this time, effort, and money, because this is useless. This study is useless for FAI. Absolutely useless. Do you see why I'm upset? And this was, you know, presented, proposed, approved, funded, studied, done, and published. Understand that. Okay. Like, I'm not even going to address the FAI part because, we need to ask, what's the compensatory patterns between a cam deformity, a pincer deformity, a multimodal deformity? Are there common themes that stand out, pain patterns that stand out that we don't already know about? Are there then exercise considerations then thereof that may be subtype beneficial? Ergo, if you have a cam versus a pincer, are there seemingly better squat variations or lunge variations to help? Like, that's a different question than this, because you picked a terrible squat intervention to compare, because the natural mechanisms involved with anybody doing these two squats respectively and the measurements you used to justify your conclusion were atrocious. Well, we're going to use, joint range of motion and squat depth. Going to be different guaranteed. Absolutely going to be different guaranteed. Like, we could have said the same thing, like, is somebody going to squat deeper in a front squat versus a low bar squat? What is the joint angles going to be at the hip and the knee respectively? And, they're going to be different. The way that the body is being loaded, even if you're doing a traditional variation of a front squat versus a low bar back squat, are going to be so different. The position, center of mass, and how the person orients themselves under the bar to drive that bar back up are almost two entirely different things to begin with. The front loaded rack position is going to have the weight being pulling you farther forward, which means you're going to have to sit back farther, which means you're going to use more quads, which means you're going to sit deeper. You're going to have a deeper knee angle, respectively, because of the orientation of the rest of your body around that moment arm, that line, that center. You put that bar low on your shoulders, low on your back, it's now back, you're kind of pitching forward and you're more directly under it. You're going to use a lot more hip drive and hip torque, which means my hip flexion angle is going to be much greater. I'm essentially going to be pinching my squat or my hips off because of when I sit deep into that squat, where that bar is positioned. That's what my body is going to do to allow me to sit down before I drive the bloody thing back up. So you're telling me, hey, with a squat, we're going to tell a person to squat normal. We're going to get relatively good understanding of how they squat. Now we're going to tell them to pause. Whether they know it consciously or not, They understand that by removing the bounce, it's a different movement altogether. Same bar position, same center of, line of drive, all of that. So the joint angles should be the same, but because you remove part of the person's ability to get up out of the squat, they're naturally going to orient themselves to not sit as deep. It would take an external coach, an external stimulus on average for a person to sit down as deep. And I can tell you that bloody sucks. I've done it because it's like, all right, I caught myself. It's like, oh, I'm not sitting down as deep as I normally go, and it not as deep as where I have my issue. So I put a box, or you put something that you can see to get you down to that position, and it is a love-hate relationship exercise. If it's the right one and it's good for you, great. It's obviously going to be great. But it's not something personally for me, let alone a lot of people are going to go out of their way to train because that exercise is bloody hard. So if you're a masochist, great. Join the club. I'll make t-shirts. But just understand that I brought this study out here because it gets me so fired up because to my mind, it's like, how do you not, like, if you're supposedly studying this, how do you not even take that into consideration as being an issue? Like, I'm going to reread this just to see if there's a part of the discussion that I missed, in which case I'll apologize. But from my overview. Like I took 3 minutes to kind of skim through it. So if I missed something in my skimming, I apologize. I really do. But at the very least, um, I the skimming of it led me to just being terribly frustrated with what was being studied and why, and trying to differentiate between two very different movements. Um, yeah, I think I'm gonna, you know, give me a moment. I'm gonna skim this one live. Okay, I'm still mad. They even said it though. So why did they leave the conclusion up front the way that they did when even they admitted that that's a possibility? Well, look at this. I scroll down here to a second conclusion part. Um, do. It is also likely that anticipation of the hold alters movement patterns at maximum squat depth. So then why did you leave the I am so confused with the study and why they published it the way they did and why they phrased things the way they did. No, this one still leaves me mad. They even said it and they left it this way. Mm, mm. Moving on. Age-specific modifiable determinants and nonlinear risk patterns of habitual low back pain in a large medical checkup cohort. Basically, what did they piece out? Did anything have really an age determinant on what is more risk averse to developing low back pain? This is just a way for us to kind of highlight a few other things as well to you. Like we've said it in times past, but it's always worth re-mentioning as far as what leads you to have or what puts you at risk for developing low back pain. So they subcategorized it, between young and older adults. And in young adults, a few things that seem to stand out included higher body fat percentages, lower HDL cholesterol, for some reason chewing difficulty, but that could be for comorbid reasons, like chewing difficulty had other conditions tied to it that also were then therefore tied to low back pain. A frequently animal high or high animal fat intake, and non-restorative sleep. which I think was actually across all studied age groups. Now, moderate sweat-inducing exercise was protective, also across seemingly all age groups. Now, in older adults, age obviously is something that plays a factor. The older you are, the more likely you're to develop it anyway, because age and time are huge, uh, well, factors in most chronic conditions that you're going to develop that tie in with low back pain. Now, this one was not lower HDL cholesterol, but elevated low density or LDH cholesterol, low platelet count, smoking, overeating, and poor sleep were also risk factors, while exercise and brisk gait were protective. So definitely some overlap here. Ways that you can kind of address things for the age groups, which again, if you take a look at the actual ages in of themselves, all of those risk factors make sense because they've been talked about in other studies. A lot of them are kind of obvious, well, yeah, makes sense sort of situations, and we can go from there. But I've got two more studies, and if you're not tired of me, I'm getting tired of me. So let's just hurry the last two up here. Hip abductor strength predicts injury falls and mediates the balance confidence fall relationship. Reason being is falls aren't really front to back. Like, it's not often that somebody is tripping and falling face first or face back. Does it happen? Yes, it still happens. However, you have your arms in front of you, and there's a lot of different movement patterns at play where you're not at as high of a risk of developing an injury falling forward. A lot of it is when you fall out to the side. That's where a lot of the injury rates stem from, for reasons like, you know, muscle weakness and strategies. People are very poor about any side to side movements, so you're more likely to actually like fully fall with higher forces, as well as the fact that these people oftentimes will develop osteoporosis. And if you have osteoporosis of the hip and you fall directly on the hip, you're gonna have a broken hip, and that increases mortality, etc. So this one is just kind of showing that, hey, look, if you address that common issue where you fall out to the side, add more strength and power to the muscles that control or would catch you if you fall out to the side, you're going to reduce your injury fall risk. Okay. So get moving, get active, and make sure you don't neglect the muscles that move you from side to side. If you're thinking like, man, I don't want to fall, well, then you can't just train forward lunges. You got to train side lunges and side steps and all of those fun things. And last but not least, two different mobilization approaches on the AC joint distance in overhead athletes with subacromial impingement syndrome, a randomized control study. And this one showed that a Mulligan technique, or mobilizing in various positions with or without movement, it's typically more with movement, in various arm positions, whether it was down to the side, out, up, etc. A day after the treatment was done, they looked at the joint space via ultrasound, and both seemingly improved joint space. But it seems like that Mulligan technique, where you're actually getting in there and moving it with or without patients actively moving the joint as well, seems to buy you more space in there. So if you're suffering, impingement syndrome, a lot of patients will baby it or avoid these positions because it hurts. Nobody's blaming them. However, if we get a little movement in there and just kind of help the patient, so to speak, doing the movement, you can, even if it's not buying space, like they measure, like you're buying space, but even if you're not buying space, you're able to show the person's body that the movement doesn't have to be painful. And in combination with potentially giving it more space, you can help a lot of people with these subacromial impingement syndrome. So I know a lot of people will go in and do some sort of cleaning up of the shoulder, like debridement, or they'll get a rotator cuff repair that they maybe didn't need, maybe didn't need. They'll clean up the cartilage, they'll tighten things up, there's a lot of different surgeries, like they'll shave off parts of the bone or of the acromion to open up more space, which those surgeries have atrocious rates of success. It's just more a matter of, we don't know what to do, so we're just going to do this approach, and this is what we've always done. It's tradition. You really need to question that, and it just looks like if we're able to go in and help patients with these movements, which is what these techniques are, you can, in all likelihood, help them. Okay. I have spoken way too long, and I'm gonna go from here. Hope Thank you for sticking with even if you ran this thing at double speed. Thank you. But let's clip these up and turn these into a lot shorter and more digestible pieces for everybody on the other end here. Till next time.